So, we're gonna start with acute aortic dissection. What are the reasons? The most common one and the most important one is chronic uncontrolled hypertension that results in weakening of the aortic wall that is prone to higher systolic impulses. Marfan syndrome because it leads to improper or weakened connective tissue that is prone to becoming dissected and does not have that structural stability. Cocaine use, especially on a person who has a history of chronic uncontrolled hypertension, because cocaine causes sympathetic overactivation, leading to a rapid and acute rise in blood pressure in the ranges of 200 plus, that can trigger dissection in an already weak aorta. So what are the symptoms? The presentation is usually, because it happens acutely, there is acute severe chest pain that radiates to the back. So that is the most hallmark presentation, and you need to tie in the history of uncontrolled hypertension or a connective tissue disorder and the acute onset, the nature of acute onset to make this diagnosis. The X-ray is going to help you as well, and other findings such as pressure variation, systolic pressure variation between the arms. What is the reason behind this? The reason is, you follow this diagram here. Whenever there is dissection, just follow the cursor here. Whenever there is a dissection and the blood starts to creep in and fall, it forms a so when this dissection flap is formed, that can cause the pinching of either the left or right arteries that are present here. This is the brachiocephalic artery, and this one is the left subclavian. As you can see in this diagram, the dissection flap is pinching the left subclavian artery that supplies the left hand. So the systolic blood pressure in the left hand would be felt lower than that of the right arm. So depending upon which vessel is, if the right brachiocephalic artery is pinched, that is going to result in reduced systolic blood pressure in the right arm, because the brachiocephalic artery gives rise to the right subclavian artery. So that is how the pressure difference is created. Usually what happens is, the pinching happens in the left subclavian artery that is branching off the aorta here, where my cursor is pointing. That results in a reduction in systolic blood pressure in the left arm, whereas the right arm has a greater systolic blood pressure, and the difference is usually of a 20. So this is how the blood pressure difference in aortic dissection happens. That is, in summary, just the pinching of the outflow vessels from the aortic arch, usually the left subclavian, resulting in a reduced systolic blood pressure of the respective arm. So, aortic dissection, what are the symptoms that can, or the complications that can result? Let's discuss one by one, and I'll explain all the reasons behind each one of them. So, stroke, carotid artery, why can this happen? Just as I explained you guys, the left subclavian artery can be pinched, resulting in a reduced systolic blood pressure. If the dissection proceeds like this, goes upwards into the carotid artery, that can result in reduced blood supply to the brain, resulting in a stroke. So if it travels upwards along the branching aortic arch vessels, it can result in stroke if it causes dissection of the carotid artery, resulting in narrowing of the blood supply to the brain. Acute aortic regurg, why can this happen? That's also really easy. As you guys can see in the type A dissection, where the dissection starts here, if the dissection flap follows downwards to the base where the aorta is protruding out of the heart, it can penetrate the pericardium that surround the pericardial sheath that surrounds the heart, and the blood starts filling the pericardial sheath. So this is how the blood starts to accumulate in the pericardial sheath, causing reduced ability of the heart to expand during the filling process, causing tamponade. So compression of the subclavian artery results in difference in the systolic blood pressure. If the dissection goes upwards along the carotid arteries, it can cause a stroke. If the dissection invades the pericardial sheath of the heart as it propagates downward, it can cause tamponade and acute aortic regurg. Okay, I just explained the tamponade here, pericardial effusion or tamponade. I did not explain the acute aortic regurg. So why does that happen? The reason behind acute aortic regurg is due to dilation of the aortic root. As the dissection flap goes down, it causes bulging or expansion of the aortic root as the root fills with blood, and that compromises the closure integrity of the aortic valve. That results in regurg of the blood since the aortic valve does not close completely as the aortic root dilates. So that is how you get aortic regurg. Acutely it develops because the dissection happens acutely. You're gonna get all these symptoms acutely. Yeah. Aortic, we've covered stroke, we've covered acute aortic regurg, Horner syndrome. If the sympathetic plexus involved results in Horner syndrome, myocardial ischemia and infarction. Why does this happen? It's really simple. The path that leads the blood from the fake channel to enter the pericardium, the surrounding area also has the coronary blood vessels there. So if that channel invades deep enough, it can also result in compression of the coronary blood vessels, resulting in acute MI, and that is how you get a myocardial ischemia or infarction as well. So basically, if the dissection progresses downward, it can cause dilation of the aortic base, resulting in regurg. It can enter the pericardial sheath and cause tamponade effusion, and if it blocks the coronary blood vessels that are emerging right here at the base of the aortic root, that can cause coronary or myocardial ischemia as well. Hemothorax. So if the blood leaks from the dissection flap and enters into the thorax, it can cause a hemothorax, that is just simply blood in the chest cavity. Renal injury. Why does this happen? That happens in type B dissection, where the dissection flap or the dissection channel goes downwards. In the type A, it starts here and it usually progresses downward into the heart, causing the tamponade effusion, regurg. But if it travels down as happens in the type B, it can result as this is the bifurcation of the aorta, and before this comes the renal artery. So if it pinches the renal artery just like it pinches the left subclavian artery, that can result in a reduced blood supply to the kidney, resulting in acute renal injury. Abdominal pain, mesenteric arteries, lower extremity, paraplegia, spinal arteries. So the higher ones that also make sense are the stroke, acute aortic regurg, really high yield, myocardial ischemia infarction, really high yield, pericardial effusion tamponade. The king of high yield here is this pericardial effusion tamponade. Hemothorax, yeah, if the blood leaks into the chest cavity. Renal injury, AKI, yeah, that also happens. So I have explained all the reasons behind all the symptoms, so it can be really easy for you to make sense of what acute aortic dissection is gonna cause. Severe tearing, chest pain, radiates to the back, pressure difference, I told you the reason, and all the complications I also explained them. So how are you gonna confirm the diagnosis of aortic dissection? The only way to confirm is to see the dissection flap and the false channel, and that can be done if you do a enhanced contrast enhanced CT, where the contrast goes into the blood and that shows a false lumen, just like my cursor is pointing here, and a dissection flap. That confirms the diagnosis of aortic dissection. So we have to move further than just what to do to confirm the diagnosis. When are we gonna do? Because this is a acute life-threatening condition. So when are we gonna do CT? When are we gonna just go for the operating room and open the chest and repair it? I'll explain that further down the lane as well. But before that, we need to give it a read. Chronic systemic hypertension is the most important predisposing risk factor. Why? Because it weakens the blood vessel, and it's just a matter of time when they give up and the dissection starts to happen. In addition to chronic hypertension, acute or transient increase in blood pressure. What happens in cocaine use? It's the same. What happens when you lift really heavy? It happens the same. But usually this occurs when you have uncontrolled chronic hypertension. On top of this, you get acute rise, you get a dissection. Is frequently noted as a precipitant. Usually the weakening is ongoing, so these things can precipitate the cocaine and heavy lifting. Patients are usually older because the weakening of connective tissue of the aorta takes time, and may have a prior aortic aneurysm, which further points to the fact that the connective tissue has been really weakened. Atherosclerosis alone does not increase the predisposition to aortic dissection, although it is frequently present. So, mainly the reason is weakening of the connective tissue. That is because of constant high systolic impulses. That is chronic uncontrolled hypertension. So now they're going to explain all the complications that I already told you about. Retrograde extension of the intimal tear. Retrograde means that it's going to extend back. It can lead to acute aortic regurg with rapid elevation of left ventricular and diastolic pressure. Patients can develop sudden onset worsening chest pain, hypotension because there is acute regurg happening, pulmonary edema because the blood is going to back up into the pulmonary vasculature, orthopnea because the lungs are filled with blood, filled with fluid, and once you lie down you cannot breathe that well, along with early decrescendo diastolic murmur of the AR. So what are they going to give? They're going to give you all these symptoms, and then they're going to tell you that on the left second or third intercostal space you can hear on auscultation a decrescendo murmur because the aortic regurg and pulmonary regurg murmurs are heard on the left intercostal space of second or third left sternal border, second or third intercostal space, A and P regurg line, where I told you guys earlier. That is where this aortic regurg sound is heard, and the nature would be decrescendo. In the systolic part of the contraction of the ventricle, you're not going to hear. As soon as the ventricles relax, the blood is going to gush back as it regurges, and you're going to hear a diastolic decrescendo murmur. Why decrescendo? Because initially the backflow of the blood is going to be maximum, and slowly it's going to become less. So that's why you get initial high voice followed by, as the blood the regurg slows down, the voice is going to decrease like this. So you're going to decrescendo, you're going to get a decrescendo sound, high at the start, low at the bottom. Ascending aortic dissection can propagate proximally into the pericardial. Yes, retrograde extension can cause invasion of the pericardial space, leading to cardiac tamponade, which causes reduction of the cardiac output, which can cause dyspnea, hypotension, and JVD as well. So you're gonna get jugular venous distension, all those good things about the cardiac tamponade, muffled heart sounds, and on inspiration you're gonna get a spike in JVD because the ventricles cannot be filled and the preload increases as you breathe in, but the ventricles cannot accommodate the blood, so you get a sudden spike in JVT upon inspiration. That is also a sign of cardiac tamponade. You're gonna get hypotension because the blood is not filling the ventricles and thus it's not pumping the blood forward. But you are not gonna get pulmonary edema when it comes to tamponade, but when it comes to aortic regurg, yes, you will get. So these are just simpler explanations to a bigger cause. That is, once you identify this, you're going to be able to localize what's the reason. So because the right-sided heart chambers are affected, lungs remain clear in cardiac tamponade. I already told you guys. So this is another table that shows that the ECG chest X-ray shows mediastinal widening because there is a fake intimal. Let me just draw it down for you guys. Since you have since this is the aorta, and now you have a fake channel going on here in the aorta that is causing the causing the blood to rush in, and since the fake channel is formed, the aorta expands. So the end result would be the aorta becomes bigger. So when you see the X-ray, you're gonna see a wider aorta signified by a widening of the mediastinum because there's a fake channel. Now the aorta is occupying more space than usual, so you get a mediastinal widening. So that is the reason behind the mediastinal widening in this case. So that is the reason for mediastinal widening. So the diagnosis is confirmed by CT angiography that shows you the intimal flap. So what is the management? The highest yield management is reduction of the systolic impulse. You need to reduce the systolic blood pressure as soon as possible so that the dissection does not propagate. That is the biggest thing that you need to remember about this. And whether you're gonna repair it surgically or not, that is another debate. But for the first thing that you need to do is reduce the systolic impulse. The goal of initial therapy is reduction of systolic blood pressure. Yeah, obviously the patient is in pain, you're gonna give pain control meds, but the main thing is to reduce the systolic blood pressure. Why? Because it is gonna prevent the further propagation of the dissection. So if the blood pressure is not controlled by just beta blockers, you can use nitroprusside, but still I am emphasizing it again and again, the mainstay treatment is beta blockers. So I'm gonna jump on to the main stuff here when it comes to step 2 CK. I'll go up and explain everything. If you suspect aortic dissection in a patient, sharp, sudden onset, tearing chest pain that radiates to the back, history of uncontrolled hypertension, and just did cocaine recently. So you are suspecting aortic dissection and the patient is unstable in this case. What do I mean by unstable? That you suspect that the patient has had cardiac tamponade, or the patient has had acute aortic regurg, or you suspect that the blood is leaking out and the dissection has propagated full length across the thickness of the aorta and the patient might bleed to death, then you're gonna go for thoracotomy if the patient is unstable. Similarly, suspected aortic dissection, same scenario, patient is stable. You're gonna give beta blockers and you're gonna confirm the diagnosis with CT scan. So if the patient is stable, you do CT. If the patient is unstable, you open the patient. That's it. That's what I want to hammer down. Suspected aortic dissection, patient stable, has contrast allergy. You cannot do a CT because the patient has contrast. You're gonna have to go with transesophageal echocardiography. So now we can come to, so if the patient is unstable, you open the patient. If the patient is stable and does not have a contrast allergy, you do a CT scan of the contrast enhanced CT angiography, because angiography is going to visualize suspected aortic dissection, patient stable, has contrast allergy. Yes, I wanted to do CT, but now will have to do with transesophageal echo. Now let's move on to another scenario. Treatment for ascending aortic dissection. Just keep in mind, because ascending aortic dissection has a retrograde extension, it can cause tamponade, it can cause myocardial ischemia, it can cause acute aortic regurgitation. It's more life-threatening. So when it comes to ascending aortic dissection, you're gonna do surgery. You're gonna give labetalol in all cases. I've written here, labetalol given in all cases regardless of type A or type B. So they are gonna tell you in certain cases whether the dissection is type A or type B. Treatment for descending aortic dissection, I told you guys that type A is more dangerous, type B is less dangerous, so you just do go with the labetalol initially. So they give you type A dissection, and how can they give you a type A dissection? They might tell you about aortic regurg, you automatically assume that it's a type A. You go for a surgery. If they tell you type B, they're gonna give you a type B. What are you gonna do? No surgery, just go with the lipidolol initially. Whether we're gonna perform a surgery, we'll decide it later. Type B dissection complicated by AKI. Now you do a surgery. So basically, type B dissection is less prone to creating complications. That's why you just go for labetalol. And type A dissection is more prone to creating complications. That's why we just go for surgery at the start, not just labetalol. We will give labetalol, but yeah, we proceed to the surgery. But if the type B causes complications, you also go for the surgery. I'll write it down here for you guys because the summary really helps. It's a lot of information, and if you just get the summary down, it's the end. So I've written down here a summary as well. Type A dissection and type B dissection with organ malperfusion is treated with surgery. Type A dissection always, type B dissection with organ malperfusion is treated with surgery. When it comes to what diagnostic modality you are going to use, it depends on whether the patient is stable or not. When it comes to whether you are gonna go for surgery or just labetalol initially, depends on the type of dissection. So type B dissection, all we already complicated by AKI. We know we are gonna go for thoracotomy in this case. But if they ask you that the patient is stable, basically they'll just give you that the patient has a dissection and now has AKI, and they ask you that the patient is stable, and they ask you for a diagnostic modality. As I told you guys, if the patient is stable, we do a CT. But in this case, the patient has AKI because of dissection, then we go for transesophageal echocardiography. Why? Because the kidneys are already compromised. They cannot take any sort of contrast in this case. BP is different between the arms refers BP difference between the arm refers to aortic dissection. I told you guys that it causes pinching of the left subclavian artery. That's why you get difference in the BP. Thoracic aortic dissection, where not only the BP different between the arms, but is also different between the right and left legs. Why? The same phenomena happens here. Let me just go back to the diagram. As I told you, it's the pinching of the left subclavian here, caused by the dissection flap. Similarly, if the dissection flap, as you can see and visualize in this diagram, type B, the dissection flap is propagating downward, and it's gonna pinch this side, the left side of the aortic bifurcation. So that's why the left leg is gonna have systolic blood pressure in the dorsalis pedis, and the posterior tibial artery is gonna be less compared to that of the right side. So it's a variable thing. If it's type B, you can get a difference between the upper and left upper extremities and the lower extremities as well. If it's a type A, just pinching depends on where the pinching is happening. The difference in blood pressure is a real thing. So that's what I just wanted to hammer down. It's not just about the upper extremities, left and right upper extremities. It can also be about the left and right leg difference in the systolic blood pressure. Aortic dissection must be differentiated from MI. Always review an ECG. Even though aortic dissection that with the retrograde extension can cause MI, but you always review an ECG. Early identification of aortic dissection is essential because therapies for similar presenting conditions, for example, aspirin, heparin for myocardial infarction, are contraindicated in case of aortic dissection because they can make the patient further prone to bleeding out. So in this X-ray, we can visualize the mediastinal widening. I told you guys the reason behind it, because there's a false lumen created. Overall thickness of the aorta has increased. That's why you get a mediastinal widening here. They've shown a CT angiography which shows an intimal flap causes by and a false lumen here as well. This is the descending aorta. This is the ascending aorta. When you visualize a CT, the ascending aorta is at the front and the descending aorta is at the back, because when the aorta, uh, let me draw it how. So if this is the heart and this is the aorta coming out, the aorta comes out at the front and then it goes backwards. So when you do a CT and these are the ribs of the patient, and the patient is lying, so you are seeing the patient from downwards. As you can see, this is the anterior of the patient, these are the ribs and the spinous process of the patient, this is the left arm of the patient, this is the right arm of the patient, and you're visualizing the patient from the downwards. Patient is lying down, so this part is anterior, this is the ascending aorta, that is this part, it is protruding out of the heart, and as it makes the arch and turns into descending aorta, it goes backwards. So this is the descending aorta, and you can see the flap forming here and here as well. So I just also wanted to explain how you make sense of the CT scan. It can be a nuisance sometimes. So type B dissection, no malperfusion, you go for just labetalol and you are gonna wait and watch policy. But if it is complicated by malperfusion like mesenteric ischemia, you will go for thoracotomy, manage medically. To thoracic or abdominal, no malperfusion. Yeah, it's saying no malperfusion. You just medically with beta blockers. Type B dissection, complicated by organ malperfusion, urgent surgical repair. So diagnostic approach to aortic dissection. Suspected aortic dissection, as I told you guys, the risk factors, the biggest one is chronic uncontrolled hypertension. Marfan syndrome is also Reason Marfan syndrome, let me just give you a recap. It's a genetic mutation in connective tissue, namely in fibrillin 1, that results in weak connective tissue that is overly stretchy as well. The physical manifestations would be a tall, slender body, arms longer than the rest of the body. You can get chest deformity as well, pectus excavatum or carinatum, in which the chest is either sunken or protruding out. And one more high yield thing about Marfan syndrome is that if you suspect a patient with Marfan syndrome, you're gonna do what? The biggest cause of mortality in such a patient is aortic aneurysm. So you screen such a patient with echocardiography. They'll give you, this scenario also usually comes up, they're gonna give you a patient who has characteristic features of Marfan syndrome. And in order to hammer that down, they're gonna also tell you that the patient had had lens dislocation on minimal trauma. So they'll give you a eye examination where when you see the iris is just like tremulous iris, which the reason behind is that the lens posterior to the iris has been dislocated. So when the patient moves the eye like here and there, the lens moves and pushes back on the iris, and the iris just vibrates like this. They'll give you this finding and characteristic findings of the physical appearance and ask you what is the next best step, and you're going to select echocardiography in order to visualize the aortic aneurysm, whether it's developed or not, because that is the main reason of death in this case. So that also results in aortic dissection because it's the connective tissue is weak. So we'll discuss everything as we go on. So the characteristic symptom: tearing chest, abdominal pain radiating to the back, uh, systolic blood pressure difference between the left and right arms, or if it's descending, can be between the left and right leg. And the murmur can also develop of aortic regurg. It would be diastolic decrescendo murmur on the left sternal border at the A and P regurg line, as I told you. So you do a chest X-ray first. If you see mediastinal widening, that further points towards dissection. And then you're gonna evaluate the patient with CT scan that confirms the diagnosis. If the patient has a AKI due to descending, you can do a CT. You'll go for a esophageal echocardiography instead. If the patient is unstable, you skip all the bullshit and you just open the patient with thoracotomy. And as I told you about, if they mention the dissection is type A and the patient is stable, what are you gonna do? You're gonna do medical management as well as you are gonna open the patient. If it's descending dissection and no signs of organ malperfusion, you just give beta blockers and wait. Transesophageal echocardiogram preferred diagnostic study in patients with renal insufficiency or hemodynamic instability. If the patient is hemodynamic unstable, you just go for a thoracotomy. And while you're doing the thoracotomy, taking the patient to the operating table, you can perform a transesophageal echocardiography just to give you a more sense of diagnostic accuracy. CT angiography is preferred in hemodynamically stable patients. However, it requires use of contrast and should be avoided in patients with renal insufficiency, prior renal insufficiency, or an AKI due to dissection itself. So I have summarized it really well here. CT angio only done if patient is stable. If not, then transesophageal echo while taking to OT. If stable but renal issue, then also transesophageal echocardiography. So this summarizes everything really well. Let's move on to pulmonary embolism. So the modified Wells criteria is really important when it comes to pulmonary embolism. It is done to see whether the diagnosis of pulmonary embolism is likely or unlikely. And I'll give you a really good summary of that as well when we move forward. So the highest yield points here are the +3 points for if the patient has signs of DVT and if there is no possible alternate diagnosis other than pulmonary embolism. And the next one that you need to remember is the 1.5 points. Previous history of pulmonary embolism or DVT, obviously it can occur likely again. Recent immobilization. You just need to remember clinical signs of DVT at the moment when the patient has pulmonary embolism, that gives you 3 points. And previous pulmonary embolism or DVT, that gives you 1 point. And recent heart surgery, or immobilization. That also give you 1.5 points. So you just remember these 3 points, they are gonna be more than sufficient for you. So if the score is 4, pulmonary embolism is unlikely. If it's more than 4, it's likely. So once you reach to this point, whether you know whether the embolism is likely or unlikely, that is when you move forward. So this is a table, this is an algorithm which decides the treatment, and I am gonna summarize this algorithm really well for you guys. So in order to summarize this algorithm, let me write something. So this table only tells you this algorithm only tells you whether you're gonna do the CT pulmonary angiography or you're gonna do D-dimer. It does not include the fact whether you are gonna go for anticoagulation or not, which is the mainstay treatment for pulmonary embolism. Heparin is the mainstay treatment for pulmonary embolism because it prevents further clot propagation and it prevents clot extension as well. So this table is only telling you that if you think that the P is likely, you do the more definitive testing, that is CT pulmonary angiography, where you inject the dye into the vasculature and it shows you the obstruction in the pulmonary vasculature. And if it's unlikely, you just do a D-dimer first in order to make sure that the diagnosis is pointing towards PE. And then if the D-dimer level is more than 500, you do the accurate testing. But this flowchart does not show you about anticoagulation. That also comes into play. So I've summarized it in a better way. First of all, the step, you just remember 3 steps for pulmonary embolism. If you suspect pulmonary embolism, you're going to use the modified Wells criteria to decide whether pulmonary embolism is likely, which means score is more than 4, or unlikely, which means score is 4 or less than 4. If likely, if unlikely, then you're gonna do, wait a second. If unlikely, then you're gonna do a D-dimer in order to just rule out. And if it's likely, you move on to step 2. If PE likely, that is the score is more than 4, then you see if the patient has a contraindication to anticoagulation. Because I've not emphasized on this flowchart more because the treatment goes hand in hand. The diagnostic treatment and the management, that goes hand in hand. That's why you need to keep both of these factors in mind. First of all, you decide whether the PE is likely or unlikely. If the PE is likely, then you see whether the patient has a contraindication to anticoagulation. What is the contraindication to anticoagulation? If the patient had a recent surgery and there is a problem that the patient might bleed to death or anything like that, you see whether the patient can receive anticoagulation. If the patient can receive anticoagulation, you move on to the step 3. That is, if no contraindication, then start heparin as soon as possible and then do a pulmonary CT angiography to confirm the test. If there is a contraindication that you cannot use heparin, then you are gonna first do a CT. Then you're gonna resort to the treatment, which is gonna be, you're gonna place an inferior vena cava filter that is gonna prevent any clot from further lodging into the pulmonary vasculature. So there are only 2 treatments for pulmonary embolism: anticoagulation, that is heparin, or inferior vena cava filter, which is the IVC filter is only used if anticoagulation cannot be done in a patient. So what are you going to do? You're going to first of all see the symptoms of the patient, and if you decide whether it's pulmonary embolism, you're going to use the modified Wells criteria and see whether PE is likely or unlikely. If the PE is, once you've decided that, you're gonna see whether the patient, if the P is unlikely, the diagnosis of the charts, you just do a D-dimer and rule out the disease. If the PE is unlikely, you're gonna move to step 2. That is gonna be you're gonna see whether the patient is can be anticoagulated or not. Once you've decided that the patient can be anticoagulated or not, if you can anticoagulate the patient, you anticoagulate the patient first, you start heparin, then confirm the diagnosis with a CT pulmonary angio. If the patient has a contraindication to anticoagulation, then you first do a CT, then you place the inferior vena cava filter, because IVC placement is a more invasive procedure, so you confirm the diagnosis first. And if things are creating trouble for you, I'll just write it down that CT pulmonary angio is only done if PE is likely. So, the takeaway point from all this discussion is CT pulmonary angio, which is the major way to confirm the diagnosis, is only done if PE is likely. That is, score is more than 4. The order of treatment depends upon contraindication to anticoagulation. What do I mean by the order of treatment? The order of treatment means whether you do it first or after. If there is no contraindication and the patient can receive heparin, you give heparin first and then do the main definitive diagnosis test, that is CT pulmonary angio. If there is a contraindication, you do the test first and then you resort to the final treatment, that is IVC filter, since anticoagulation is not possible. So, when it comes to the treatment of pulmonary embolism, you just need to remember these 3 steps and this high yield line, and that the only true treatments for pulmonary embolism are either heparin or IVC filter. And IVC filter is only placed if you cannot do the heparin. So, CT pulmonary angio, I'm gonna read it again as well. CT pulmonary angio is only done if PE is likely. If it's unlikely, do a D-dimer and get rid of it. If it's likely, you are gonna do CT pulmonary angio. When? That depends whether the patient can receive heparin. If the patient can receive heparin, you give the heparin first, then do the test. If the patient cannot receive the heparin, you do the test first, make sure that it's pulmonary embolism, and then resort to the only treatment left, that is IVC filter. And when it comes to the definitive diagnosis test, they are going to give you pulmonary CT angio, they are going to give you echo, they are going to give you ventilation perfusion scan. Do not choose the ventilation perfusion scan because it's a less accurate way of diagnosing pulmonary embolism. D-dimer is also a really inferior way to diagnose. It just gives you a hint about whether the patient is in a hypercoagulable state. If the D-dimer level is greater than 500, then you can think about pulmonary embolism. Other than that, you can exclude. So these are inferior ways. The most important way is the CT pulmonary angio that confirms the pulmonary embolism, and that is only going to be done if PE is likely according to Wells score. Let's move on to hypertension. So this question also really comes up a lot. They are gonna give you a person who comes to the clinic. I'll also write it down the normal presentation of this scenario. The person is gonna come for a wellness visit, and you're gonna measure his BP. His BP is gonna be 140/80, and then they are gonna ask you, what are you gonna do next? Are you gonna start the patient on hypertensive medications? Are you gonna do the blood pressure measurement at the same day and then start the medication? Are you gonna just reassure the patient? What are you gonna do? The answer would be that usually there's a syndrome called white coat syndrome, where the patient, whenever presents to a doctor, the anxiety levels result in a temporary or transient increase in the blood pressure. So a hospital visit that gives you a blood pressure of 140/80, or basically a systolic blood pressure 130 or greater, does not mean that the patient has hypertension. In order to make it sure, you're going to ask the patient to go home and measure his blood pressure, or you're gonna ask the patient to get an ambulatory blood pressure reading device that measures his blood pressure in the home. And that consistent rise in the blood pressure at home is gonna decide whether the patient is hypertensive or not. And if the patient cannot measure his blood pressure at home, you're gonna measure his blood pressure in the office for 3 consecutive visits, 1 week apart. And if the blood pressure is consistently high in all of these 3 visits, and while then you're going to diagnose hypertension in that patient. And during those visits to the hospital, when you are measuring the patient's blood pressure, the patient must be left alone so that anxiety can be curbed and you get an accurate reading of the blood pressure. So 50-year-old, first visit to the doctor, recently got insurance, that's why it's his first visit. BP is 140/90, never measured before. Ophthalmoscope shows retinal vessel nicking and hemorrhage, HbA1c 6.5. Next best step. So what is the answer here? The options are home BP monitoring for 3 days, start hypertensive drugs, reassurance. So as I told you guys, you cannot always rely on one reading, but in this case there is an evidence of end organ damage, that is hypertensive retinopathy. So you don't need to go and confirm by three or more readings and take 3 or more weeks for the patient to start the meds. If there is evidence of end organ damage as a result of blood pressure, then you start the meds. So that is why I kept this question here. And now if we go back to this flow chart, you're gonna see evidence of end organ damage, or if the blood pressure is really high, like 120 over 180 or more, then you start. You don't need extra readings then. So just two scenarios. Averagely increased blood pressure, you send the patient home, ask the patient to measure his blood pressure at home with ambulatory readings, and then come back, or if that's not possible, 3 office readings while the patient is left alone. And if the blood pressure is really high, that means the patient is hypertensive and you're going to start him on the meds. If the blood pressure is not really high, but there's evidence of end organ damage like hypertensive retinopathy or retinal vessel nicking or hemorrhage, then that means the patient is uh, suffering from hypertensive. They can also write here, instead of retinal vessel nicking or hemorrhages, the ultrasound of they can say that the GFR is 70 or 60. That represents that the kidneys are damaged and the patient is not diabetic. And once you do an ultrasound, that shows shrunken atrophied kidneys, which represents also end organ damage as a result of hypertension. I'll write that scenario down as well. So another question in the same way, never measured before, GFR is 60, creatinine is 1.5, and let me add the ultrasound findings as well. So the ultrasound shows shrunken atrophied kidneys, no history of any medication use, because the use of analgesics over a prolonged period of time can also cause shrunken atrophied kidneys. But in this case, no history of any medication use. So you have to make a sense that this is end organ damage as a result of BP, uncontrolled hypertension. I've also added one more aspect here, that the patient also gives a history of headache sometimes, especially after eating fast food, which represents that after intake of a salty meal, the blood pressure skyrockets and that results in headache. So you make sense of everything and then you decide that the patient needs to start hypertensive medication ASAP. If everything is absent, just 140, 90, and there's no sign of end organ damage, you just ask the patient to go home, measure the blood pressure there. Laboratory evaluation of hypertension. So hypertension, whenever it comes to hypertension and you've diagnosed hypertension, you need to keep in mind the metabolic syndrome, which is a triad of hypertension, hypercholesterolemia, and diabetes mellitus. So if you diagnose a patient with hypertension, need to screen the patient for hyperlipidemia. So you order a fasting lipid profile. You need to diagnose, also see that if the patient is diabetic, you also order a fasting blood glucose level, or a better alternative is HbA1c. So that is these are the two main things that you are going to screen the patient for, the metabolic syndrome triad basically. And since you're going to also screen any organ that is prone to damage as a result of uncontrolled hypertension, which is usually the kidney, so you also do a renal functioning test, serum electrolytes. That serum creatinine represents the renal functioning test. You also do serum electrolytes, which are going to reflect whether the kidneys are functioning properly. You're going to do a urine analysis. Everything falls under the category of renal functioning test because the kidneys are really affected by the hypertension. You're going to do the metabolic triad screening. These are the important ones. So if you just, I'll give a rapid read. Hypertension is the major risk factor for CKD. That's why you do the renal functioning tests, because the risk of cardiovascular complications greater in a patient with comorbid hyperlipidemia and diabetes mellitus, which is a triad of metabolic syndrome. You do HbA1c and lipid panel. Many experts recommend a TSH for all patients with hypertension, because thyroid disease can also result in hypertension. So they can give you a scenario where the patient is hypertensive and the patient also complains of symptoms of hyperthyroidism, like the patient says that he feels really hot all the time, has been losing weight despite a normal appetite, Otherwise, he feels healthy and the patient has diarrhea as well. And they are going to give a history of thyroid disorders in the family, so you also order TSH in that case. Examples of signs of secondary hypertension, that means hypertension resulting from another reason other than this primary is just idiopathic, you cannot find a reason for that. Secondary is that you have a reason for that. One of a high yield cause is Cushing syndrome that results in high cortisol levels, and high cortisol levels result in a mineralocorticoid effect that result in fluid retention and sodium retention that results in hypertension. That would also be evidenced by hypokalemia. And a patient with hypertension, hypokalemia, abnormal body fat distribution, like more fat on the face, more fat on the abdomen, and really thin and atrophied arms and legs, that dad bod physique is gonna point you towards secondary hypertension resulting from Cushing syndrome. So yeah, you're gonna be able to have to make sense of what's happening here. See the patient scenario. I'll also write it down. So this is an interesting scenario. 40-year-old female complains of weight gain, has striae on the abdomen, TSH is normal, BP is 150/90, serum electrolytes so decrease, potassium increase, sodium. Next best step for management: start hypertensive drugs, do a kidney ultrasound, serum cortisol levels, serum renin, aldosterone activity levels. So 50-year-old female complains of weight gain, but the TSH is normal. That means that the weight gain is not because of hypothyroidism. Has striae on the abdomen. The striae can be stretch marks, but yeah, when it comes to Cushing syndrome, the striae also form as a result of uh, poor connective tissue synthesis and collagen production that results in formation of striae in the abdomen. Serum electrolytes show decreased potassium, increased sodium activity, which is a sign of increased mineralocorticoid activity. Next step for management: start hypertensive drugs because the patient's BP is more, but that does not seem like a primary cause of increased blood pressure, so we avoid that. Kidney ultrasound, can we do it? Yes, we can do it, but that won't make any sense here because they have not mentioned that the kidney is being affected in any case, or whether there's an infection or the kidney, or the on palpation there are cystic masses, nothing like that. Serum cortisol levels, yes. Why? Because it can be due to increased aldosterone, the decreased potassium, increased sodium. We are going to order the serum cortisol levels because the weight gain and the striae on the abdomen does not justify increase in aldosterone levels. The weight gain can justify increased aldosterone levels, but the striae on the abdomen do not. Why weight gain can be justified by increased aldosterone levels? Because of increased water retention, but the striae on the abdomen point towards hypercortisolism, serum renin to aldosterone activity. No. So we do assume here that it's most probably Cushing syndrome. So we order serum cortisol levels, not starting antihypertensive drugs, because if we correct this issue, the blood pressure is going to normalize itself. So they say that the ECG is also recommended as an initial evaluation of hypertension because it can show left ventricular hypertrophy. In how? Because the QRS waves are gonna be peaked, representing that the LV has been hypertrophied. So here I summarize everything. Metabolic syndrome, you see one disease, you screen for other two. RFTs are going to be done for hypertensive nephropathy to check the kidneys. TSH and hyperthyroidism can also cause hypertension. ECG to evaluate for LV hypertrophy. Serum electrolytes to see hypokalemia, to check for hyperaldosteronism or hypercortisolism. So here they have also mentioned other causes of hypertension, other secondary causes. So, renal parenchymal disease, if the kidney is not functioning appropriately, then that results in upregulation of renin angiotensin that can result in development of hypertension. And that would be evidenced by increased serum creatinine levels. Renovascular disease, where there is constriction or reduced blood supply to the kidneys. So, in order to compensate for the blood supply, the renin-aldosterone system is upregulated. That results in increase in blood pressure. So the renovascular disease, as when we discussed it earlier, there are also going to be signs of atherosclerotic cardiovascular disease in other areas of the body, that the patient may also have claudication, the patient may also have a history of MI, the patient may also have angina, the patient may also have had suffered from stroke, the patient is going to be diabetic, he's going to be hypertensive. So that is going to point towards vascular disease, and the hypertension would not be able to be controlled by three or more agents of blood pressure management. And the recurrent flash pulmonary edema represents that intermittently the kidneys retain a lot of water, so that's why you instantly get a pulmonary edema. That's called as flash. And once you start an ACE inhibitor, in this case there's going to be a abrupt rise in creatinine levels. Primary aldosteronism, that is evidenced by spontaneous or easily provoked hypokalemia. So what are you supposed to make sense of? How are you supposed to make sense of this easily provoked hypokalemia? The best scenario would be a person who gets severe hypokalemia upon starting thiazide diuretic in order to manage his blood pressure. Primary aldosteronism is gonna cause an increase in blood pressure, and if it's not diagnosed and the patient starts a thiazide diuretic, that further results in wasting of potassium, the patient is instantly going to develop hypokalemia, severe hypokalemia. That is going to point towards primary hyperaldosterone. This is a high yield point and a scenario. I'm also going to write it down downwards. And the lab findings are going to be increased aldosterone, but a paradoxical low renin activity, because aldosterone is already really high, so the kidneys stop the production of renin. So really reduced aldosterone to renin activity, and high aldosterone, low renin, and hypokalemia severe after starting a thiazide diuretic for the management of blood pressure is going to point towards primary aldosteronism or Conn syndrome. Pheochromocytoma results in episodic release of catecholamines. So you're gonna get episodic headache due to really increased blood pressure, and episodic palpitations due to because they cause sympathetic overactivation. You're gonna get paroxysmal hypertension with tachycardia. The heart rate instantly rises, and paroxysmal or intermittent manner. So the patient says that he's fine at one moment, and at the other moment he instantly feels that his head is hurting and he's got a headache and he has palpitations, that is tachycardia, because the release of the catecholamines are episodic or intermittent in nature. They don't stay raised all the time, they go up then come down. So what is the diagnostic test? Lab findings are gonna be, you do a urine metanephrines and they are gonna be high. That confirms the diagnosis of pheochromocytoma, but be wary that urine metanephrines are not always high. They are only gonna be high during an episode. Once the catecholamine surge happens, once it goes down, the urine findings can be normal. Cushing syndrome, we already talked about it. Hyperglycemia is also gonna really help you make a diagnosis. Proximal, the high yield finding is gonna be the Cushingoid body habitus, fat face, fat abdomen, thin arms and legs, uh, and then you're gonna get hypertension because the mineralocorticoid effect. You're gonna get abdominal stripe, poor wound healing, and hyperglycemia because they are glucocorticoids, the cortisol, and that is then how, and you're gonna get high cortisol levels in the blood if you do a test. Thyroid disease, yeah, you guys can read it here. Primary hyperparathyroidism, bones grown psychiatric overtones, that's a high yield mnemonic. Bones, you're gonna get bone pain. Stones, you're gonna get stones in the kidney. Psychiatric overtones, you're gonna get neuropsychiatric symptoms. Coarctation of aorta results in reduced blood supply to the kidneys. That is why the person develops hypertension, as the kidneys try to restore their blood supply. And when you measure the systolic blood pressure in the arms, it's going to be high. When you measure in the legs, it's going to be low. Do not confuse this with the difference in systolic blood pressure when it comes to aortic dissection. It's in the same extremities, left versus right. Here it's upper extremity versus lower extremity. So here they've also given where a patient came with hypertension, and they ask you the next best step: ambulatory BP readings that confirm consistent rise in blood pressure. That is when you confirm hypertensive diagnosis, and if that is not possible, 3 office readings while the patient is left alone, at least a week apart. If end organ damage, just start the hypertensive meds. For those with only mild blood pressure, diagnosis should be confirmed outside of healthcare setting with ambulatory blood pressure.